Friends, first of all, welcome to you all for another learning session from Team MAHA. As you might be knowing, last year with Dr. Jay Bhandarkar sir and Dr. Samir Sadavarkar sir, we MAHA team started this amazing journey of MAHA Subspeciality Connect with the most learned people from our branch and with a great response in the form of viewership also. So till now we have covered almost all the subspecialties and input from all these experts from subspecialties have been very useful in our practice till date. So this time we'll be covering neonatology, and to enlighten us on the various topics of neonatology, we have Dr. Sanjay Iyer sir, senior neonatologist from Nashik, and another expert is Dr. Shilpa Kalane. She is chief neonatologist at Dinanath Mangeshkar Hospital. And to moderate this session, we have two team members from Maharashtra IIT, Dr. Samir Sadavarkar sir and
Hello.
Dr. Sakshi. So without wasting time, I hand over to Dr. Samir sir for further proceeding.
Thank Dr. Amol. I am Dr. Samir for the current program moderator for today's session, and it's on the online YouTube platform and also on the Zoom. And we have the crowd of almost 200 to 2000 live stream, which as we have seen in last 2 years. And today, as already mentioned by Dr. Amol, is a NICU theme with a golden hour and peritological cases in the lessons. So to introduce the speakers and before that, to introduce the conveners and MAHA President and Secretary, I will invite Sachin Patil sir for going ahead. Just before that, I'll just introduce about the part about MAHA. So as a MAHA concept, it's like a committed to the improvement of the kids, pediatric children, and also the adolescents, not only about the social, mental, and about the physical well-being, but also psychosocial health of these children and adolescents. And also, we are also doing some social programs and social awareness programs for the parents. And so far, we have almost done 553 programs in last 2 years under the guidance of our President, Ramakant Patil sir. And also, we have 5,000, more than 5,000 members which are there on the YouTube, which have subscribed to our channel. So I'll also inform all of you that please, if you are not able to join on the directly today, you can use the YouTube live platform. And thanks to our team, includes the Ramakant Patil sir as the president, Amol Pawar sir as a secretary, and convener for this project who has taken a lot of efforts, Dadav sir, and also the vice president and convener, Dr. Shyam Chaudhary sir. And together with my colleague, Dr. Sachin Patil sir, and backdoor people means like they have a lot of importance, as actually Dr. Chitra madam, Dr. Singh madam, Mohan Warke sir, Milind Bhadia sir, Pallavi madam, Vishal Raut sir. So thanks to all of you for today's this program, and I will hand over to my friend and colleague, Dr. Sachin Patil. Sachin Patil sir.
Thank you, Samir sir. First of all, very good evening to all. Myself, Dr. Sachin Patil, wishing you all very happy Raksha Bandhan. Now, I request Dr. Ramakant sir for his words of wisdom, who is the backbone of our MAHA and most visionary person for the MAHA. Ramakant sir, please.
Yeah, am I audible? Thank you, Sachin.
Yes, sir.
And I'm a million thanks to Sachin and Samir for very enthusiastically and responsibly taking this MAHA Speciality Connect ahead under able guidance of our Vice President, Dr. Shyam Chaudhary, and a respected ex-EB member, Dr. Prashant Jadhav, and Team MAHA are ably supporting these two people. And I am really thankful to them. They are doing a wonderful work. Friends, we have got our homegrown neonatologist from our own district, Dr. Sanjay Iyer today, for giving us the golden hour management, and young neonatologist from Pune, Dr. Shilpa Kalane, to elucidate difficult cases on management. This concept has come from the trauma, the first hour management in trauma patients. Then it was extrapolated in sepsis, golden hour management in septicemia, even in all shock patients. And it is really a wonderful idea to have the golden hour management. And it has been proven beyond doubt that it has definitely decreased the mortality and morbidity if the golden hour management is an excellent in first hour after birth in ELBW, VLBW, and normal birth weight. And also, I will like to here mention, even if it is not there for today's topic, the first 3 hours, the most important thing is that the breastfeeding, early, exclusive, every time and every child. And these first 3 hours, these golden 3 hours are very important, because by NFHS data 5, still exclusive breastfeeding is only up to 51 to 52%. And for this reason, after following this golden hour management postnatally, we should definitely harp on the first 3 hours management. And that is very important. And if we follow that, then today's our motive or our aim or objective is being served. And I will fail in my duty if I do not mention presence of all MAHA AP team, our Secretary Amol, Neha, and all EB members. And again, we have got august presence of our Dr. Vasant Khalatkar, who is my friend, and he will be also giving his comments if after the both the cases and lecture will be there. So I welcome Dr. Vasant Khalatkar, and it is our duty of MAHA AP that in coming election for presidential election, we have to prove what we want. And सुज्ञास सांगणे न लगे, आय थिंक मला की त्याच्यातनं आपला हा हेतू साध्य होईल. मी फारसा वेळ न घेता, विदाउट टेकिंग मच टाइम, with this small preamble, I'll hand it over back to Dr. Sachin. Over to you, Sachin.
Thank you, sir. Actually, I request now Vasant Khadatkar, sir, to boost up our energy. Just 1 or 2 comments will be sufficient for us. Sir is always helping us to boost up our programs. So now I request Dr. Vasant, sir, please.
Thank you MAHA AP platform for giving me chance to talk. I will not take the name. These all are my friends, and I know friends are always helpful in future, not in future, past, and always in future also. So really, it's a great thing going on in Maharashtra AP. See, I am moving all over India because of my this year's motive. And I have seen never it happened. There's such activity, vast activity, major activities are going on in MAHA AP. It's every day something is there. And I know this year the state branch chapter award will be ours only. And I know the most, not only that award, the major award, as Ramakant said, we are going to get this year. I'm little bit confident because of you people. Thank you once again. Thank you. And I wish all the best. This energy should be continued. Whether whosoever will be president, whosoever will be secretary, this energy. And really, Ramakant, Amol, and his team, they taught everybody how to go energetically and how to do the program. I wish again all the best. Thank you.
Thank you, Vasant, sir. Definitely, we all with MAHA AP team definitely will rock in the Kochi Pedicon for grabbing maximum awards. Now, I think our MMC observer sir is not there. Amol sir, nahi. So now I request our first speaker, respected Dr. Sanjay Iyer sir. Please share your slides, sir. Sir is a medical director and founder of North Maharashtra's advanced NSU, that is Neocare Hospital, Nashik. Sir's major achievements is, sir had 3 concurrent reviews on erythropoietin in neonates, almost 14 general publications, in renowned national and international journals. Sir was the organizing president of MAHA 2019 at Nashik. Sir was a past president of Nashik IIP in 2019, and sir is a national faculty for various neonatal conferences. So we are very lucky to hear you, sir. Now I request Sanjay sir, please start your session, that is on the golden hour management.
And most important introduction of Sanjay is he's silent, no nonsense worker and a very soft, calm demeanor, soft spoken and excellent. And is one of the qualified neonatologists, few batches of neonatologists from Maharashtra, Mumbai.
Thank you, Ramakant Patil sir. Thank you all the office bearers of MAHA IP and all my friends, colleagues and teachers and my students. So today I'm going to discuss very important topic, as already Dr. Ramakant Patil has said, that this term has been extrapolated from the adult intensive care and trauma care. And it will change the outcome of the babies, not only the mortality, but morbidity as well. So what I'm going to cover during this 20-30 minutes, what is the golden hour strategy? What are the current resuscitation recommendations by NRP? Then we have to take certain care during resuscitation of preterm, especially VLBW and ELBW babies for temperature. Then what are the recent guidelines for delayed or deferred cord clamping? Then various modes of respiratory support in the delivery room and in NICU during the golden hour. Then judicious use of oxygen, because it is a drug, it can cause retinopathy of prematurity and other complications. And I'm going to touch upon certain specific issues of extremely low birth weight babies. When we go for resuscitation, if you see this chart, around 90% babies, they don't need any resuscitation. They need just simple care. Around 10% babies will start crying with drying, warmth, clearing of their airways and being provided with stimulation. And around 5 to 6% babies will need bag and mask ventilation. So 99% babies don't need intensive resuscitation like chest compression or medications. So we have to concentrate mainly on the baby's ventilation when we go for resuscitation. Ventilation, ventilation, and ventilation. This is very, very important for neonatal resuscitation. What do you think? Is India a part of ICOR? This is International Liaison Committee on Resuscitation. What do you think? Is India part of this committee or not? Recently, we landed our Chandrayaan-3 on Moon, and this is very proud moment for India. But also, this is also very proud moment for India that Indian Resuscitation Council Federation is now part of this ICOR committee. Along with this American Heart Association, Australian, New Zealand, all these councils, now Indian Resuscitation Council is also part of this ICOR committee. So let's talk about the background of golden hour. So as I said, ventilation and improving the oxygenation of the baby at birth is very vital for survival and long-term health of both, not only preterm, but term infants as well. And as we all know, the delivery room is a very, very stressful environment where decisions are made quickly and resuscitators need to be skilled in clinical assessment, decision-making, and bag and mask ventilation. But these babies who are premature, they are born with certain limitations, like they are structurally immature, their lungs are deficient of surfactant, they are not supported by a steep chest wall, and they are susceptible to injury. So what is golden hour strategy? So communication and collaboration, not only inter but intra-team. So using whatever evidence-based protocols and procedures we have. So basically it is a good communication and collaboration, and to standardize as many elements as possible for delivery and initial management in very preterm births. And there should be a good communication with our obstetric colleagues as well when there is an impending preterm birth. And there is the importance of collaborative counseling of the family. So first we have to sit with the obstetrician, take all the history, and then sit with the family and do a collaborative counseling. If the obstetrician is also present for this counseling, then it is very, very important. Then you have to get ready for the resuscitation. So you should have your pre-resuscitation checklist, and you should clearly assign the roles and responsibilities. Who is going to take care of airway? Who is going to take care of the drugs or chest compression if required? Who is going to call for help? So when you organize a team, you should have in-house resuscitation and management team at delivery. There should be at least 3 to 4 members, including a neonatologist or a senior neonatal fellow. Should have 1 or 2 neonatal or pediatric residents and nurses. This is especially for when you are going for a BLBW or ELBW delivery. And as I said, roles and responsibility of each member should be assigned properly. So we have to communicate with the parents, also very important, because they are under so much anxiety and fear. And the goal of this counseling is to provide a reliable, detailed account of neonatal morbidity and mortality. And it is to be done by a team, both neonatologists and obstetrician, as I said. So the first golden hour of a neonate is nothing but an excellent teamwork. The cornerstones of this golden hour bundle, we can call it as TOPS, that is thermoregulation, respiratory support, cardiovascular stability, and nutritional requirement. Dr. Ramakant already mentioned that we take care of ABCD, but we forget about the nutrition. So that is a very, very important part of golden hour. And it starts as soon as baby comes to the NICU, when it is a preterm. When it is a term baby, he should go on mother's tummy and he should have skin to skin contact and breastfeeding immediately. So what are the specific problems in preterm neonates? They are more prone to hypothermia, as we all know that they have very poor energy stores because they have very less brown fat. Then they have immature tissues that are damaged by hyperoxia. So we have to take care of how much oxygen we are giving to these babies. The weak chest muscle that limit adequate ventilation if the baby is less than 1 kg. Then their nervous system is immature, that may lead to poor respiratory drive. They have surfactant deficiency. They have increased risk of infection. In their brain, the capillaries are very fragile and they are very prone to intraventricular hemorrhage. And their blood volume is also small. So if there is a little bit blood loss, these babies can go into hypovolemic shock. And very important is highly stressed parents. So these are all the problems we face when we go for preterm delivery. So we have to prepare certain things, like we have to prepare the resuscitation kit, check the equipments and organize the team, call for additional help if required. If baby needs transfer, then we have to inform the NICU where the baby is going back or going to be admitted. Use a pre-resuscitation checklist. So this is the latest NRP guidelines. So this we have to follow for both term as well as preterm infants. What additional resources we need? We need additional trained personnel, including some skilled in intubation, and some additional strategies for maintaining temperature in these babies. So this is the ideal picture where you are going for a BLBW or extremely low birth weight baby. Then you will need a team where you will have a team leader. Then one person who will be looking after the airways and IV access if required. One person will be looking after breathing and one person will be looking after circulation, and everything has to be documented properly. You will need some additional equipments like compressed air, oxygen blender, pulse oximeter, and humidifier for the oxygen administration. How can we decrease brain injury to these premature babies? So we have to handle these babies very gently. Avoid Trendelenburg position, avoid high airway pressures when possible, because this can give rise to pneumothorax, intraventricular hemorrhages. You have to adjust the ventilation gradually based on physical examination, pulse oximetry readings, and blood gases if available. And we should avoid rapid intravenous fluid boluses, especially hypertonic solutions like soda bicarb or 25% dextro. These drugs should not be part of our resuscitation. The drugs we need for neonatal resuscitation are only two, that is normal saline and adrenaline. And very rarely we need O negative cross-matched blood. So there is no role of soda bicarbonate or 25% dextrose in neonatal resuscitation. So let's discuss some specific steps for VLBW and ELBW. So very important when we do resuscitation in adult or children, we call it as A, B, C. But in neonate, it starts with T. So temperature comes first in neonatal management. If it is a term baby and a normal delivery, the baby should go immediately on mother chest for skin-to-skin contact and breastfeeding immediately. But if you have a VLBW or especially a extremely low birth weight baby, then you have to increase the delivery room temperature. You should have a preheat radiant warmer. You can use warming pad, or you can use these polythene bags for babies below 28 weeks. So this is a live example of how you can use. So as soon as the baby is born, this baby will go into the polythene bag. So as soon as the obstetrician cut the cord, baby will be taken inside the bag and resuscitation will start along with this polythene bag. So this is a 700-gram baby that is being delivered and resuscitated in a polythene bag. So this baby's head and everything will be covered inside the polythene bag, and we start resuscitating. We will intubate the baby. We will not remove this polythene bag till the baby enters NICU. Then the baby will be brought there. Then further care will be taken in NICU. Then what about giving oxygen? So we have to take extra care when we are resuscitating VLBW and ELBW babies. So there is emerging evidence to use heated humidified gases for initial respiratory support for extremely low birth weight babies. So this resulting in more infants with normothermia compared with cold dry gases. As well as we have to avoid giving more heat or avoid hyperthermia, that means temperature more than 38 degrees centigrade. The second new recommendation by neonatal resuscitation program is delayed cord clamping. So there is a new recommendation that delayed cord clamping for 30 to 60 seconds is reasonable for both term as well as preterm infants who do not require resuscitation at birth. There are some exceptions if there is placental circulation is not intact, such as after placental abruption, placenta previa, bleeding vasa previa, cord avulsion. The cord has to be clamped immediately and baby should be taken to the radiant warmer for resuscitation immediately. But for stable babies, we can wait for 30 to 60 seconds and then we can clamp the cord. For ELBW infants also, those who don't require immediate resuscitation should receive delayed cord clamping for at least 60 seconds, and evidence has shown that these babies need less packed cell transfusion during their stay in NICU. The next comes the respiratory support for these babies. So our goal of respiratory support is to establish and maintain functional residual capacity of this immature lung. We have to use minimal oxygen concentration, where to avoid iatrogenic complications like air leaks, sepsis. Use least invasive and very gentle approach, especially in VLBW babies. We can use this T-piece resuscitator, which is also called as NeoFuck, which can give PEEP or CPAP consistently as compared to our self-inflating bag and mask. So there are certain evidence-based strategies for providing respiratory support in these babies. So to mention few, sustained inflation, CPAP in delivery and intubation in extremely low birth weight babies. A meta-analysis of sustained inflation in delivery room reported significant reduction in need for mechanical ventilation in 72 hours, but there was increase in PDA treatment in infant receiving a sustained inflation. Number needed to harm was 10. Immediate application of CPAP in delivery room to prevent collapse of these surfactant deficient preterm lungs It reduces the need for intubation, surfactant, and duration of the ventilation. And there is also significant reduction in bronchopulmonary dysplasia or death. Number needed to treat is only 25. Despite possible that a peri-viable or extremely low birth weight babies need effective positive pressure ventilation and intubation. And studies have demonstrated that although about half of 24-week gestational age infants can be stabilized on CPAP in delivery room, but very few avoided delivery room intubation. And if such baby is intubated, early use of surfactant may be very, very beneficial. So when to give surfactant? When compared to early surfactant, that is prophylactic in delivery room against early CPAP at birth, early surfactant does not show any benefit in outcome with a death or BPD. So what are the recommendations? Prophylactic surfactant should not be administered to preterm neonates below 28-week gestation. Preterm neonate with RDS should be stabilized on CPAP, and if indicated, selective surfactant replacement therapy should be administered, and it has to be given within first 2 hours of life. Then we have some evidence about insure. Insure means intubate, give surfactant, and extubate. Compared with delayed selective surfactant and ongoing mechanical ventilation, again, you can see it is superior to just giving CPAP. So these studies suggest that use of nasal CPAP shortly after birth as the primary mode of respiratory support is an acceptable alternative to elective intubation and administration of prophylactic surfactant. So the recommendation is early insure within 2 hours may be used for babies below 34 weeks with established RDS and who satisfy the criteria for surfactant administration. Then surfactant can be given by a less invasive surfactant administration technique or LISA, where we don't intubate these babies, but we use a special catheter to administer surfactant. So you can see this baby is on non-invasive ventilated support, and this baby fulfills the criteria for surfactant administration. So we can use this catheter instead of endotracheal tube. So you get ready with your surfactant dose, stabilize the baby, you vocalize, you visualize the vocal cord, and you pass the surfactant or surfcat through vocal cord. Baby is breathing on his own. Put the catheter through the vocal cord and administer the dose of surfactant with this catheter. Baby is also receiving his non-invasive ventilated support when we are giving this surfactant to this baby. So this is called as a less invasive surfactant administration technique. So it should be used in small babies. So what is the evidence? Which is superior? Insure is superior or LISA is superior? So we have this study, surfactant without intubation versus insure, intubation, surfactant, and extubation. So 21 research articles were eligible for this meta-analysis, which comprises around 20,000 babies. Data showed a significant reduction in composite outcome of stage 2 NEC, BPD, and onset of hemodynamically significant PDA when treated with only LISA. So trend towards lower pneumothorax rate with LISA was also evident, and there were no difference in the outcome of death or rates of other neonatal morbidities. So LISA may be preferred or insured for surfactant administration in preterm babies below 34 weeks gestation with respiratory distress syndrome. This was a quality improvement study done by Vermont Oxford Network. So higher incidence of survival without BPD after intubation for better practices, 63% versus 53%. So what these hospitals use? They less frequent conventional ventilation and postnatal steroids was used. Then there was increased use of nasal CPAP and reduced median time to first surfactant dose from 22 to 10 minutes after delivery. So with all these quality improvement interventions, there was significant improvement in their outcomes. Then what about giving caffeine? If baby is below 34 weeks, early prophylactic use of caffeine is associated with less incidence of BPD and PDA. There is improved blood pressure and superior vena cava flow without any difference in need for intubation or vasopressors. Next comes use of oxygen in the delivery room. So what are the recent recommendations? So whatever baby is preterm or full term, we use these targeted saturation numbers. So don't expect 90% saturation in a baby who is just 5 minutes old. For 90% saturation, you will get up to 10 minutes. And initial oxygen concentration should be room air for babies more than 35 weeks. And below 35 weeks, you can resuscitate the baby with 21 to 30% oxygen. So the term infants, you start resuscitating with room air. Preterm below 35 weeks should be initiated with low oxygen, that is 21 to 30%, and the oxygen titrated to achieve periductal oxygen saturation approximating the range achieved in the healthy term infants. So starting resuscitation of preterm newborns with higher oxygen, that is more than 65%, is not recommended. So even if it is a preterm baby, you can start resuscitating only with the bag without attaching oxygen tubing. So you will give room air. If you attach the oxygen tube and don't attach the reservoir, you will give around 40%. And when you attach the reservoir, you will give 100%. So even if you don't have blenders, we can still give up to 21 to 30% oxygen in these babies. So is there any evidence of giving low oxygen in the delivery? So this recent meta-analysis of around 700 babies showed no difference in morbidity. There was a trend towards lower mortality in the lower compared to higher FiO2 group. Then we are going to discuss some steps specific to ELBW babies. So we have to take caution when we are giving cardiac compressions and medication in these babies. For ELBW babies, chest compression and medications are prognostic markers for adverse neurodevelopmental outcome. And extremely low work rate babies who receive chest compression and medications like adrenaline in the delivery room and who have 15-minute Apgar below 2 have only 14% chance of disability-free survival. Given the high rate of poor outcomes, this family may decide in counseling before birth that they prefer to forego trials of chest compression and medication if initial ventilator support fails to stabilize the heart rate of their peri-viable units. So next come when the baby comes to the NIC or during the resuscitation itself, support for the cardiovascular system. So what is the goal for CVS? We want normal CRT, which is less than 3 seconds, normal heart rate and normal blood pressure in both preterm as well as term babies. And new resuscitation guideline recommend that 3-lead ECG or at least SPO monitor. SPO2 monitor is mandatory to monitor heart rate during resuscitation. And if you want to give any medication, give always through umbilical venous access or endotracheal tube access. Then there are various causes of shock. But if you are fortunate to have bedside functional echo, so very important to find out the cause of shock, and flow within the superior vena cava considered as a good surrogate marker for cerebral perfusion. So you can avoid intraventricular hemorrhages in this baby if you take care of supravenacular flow. Then, as I mentioned, ABC is not important, but nutrition is also very, very important. So if a baby is stable term infant, he should be kept in skin-to-skin contact with mother. Breastfeeding should be done within first 30 minutes. So all babies who are born by normal delivery, even term babies who are delivered by cesarean section, they should go to breast within 30 minutes. Then fluid requirement will depend on the gestational age of the baby and what is the sensible and insensible water loss and what type of care, whether open care or incubator care you are giving. Accordingly, the fluid requirement will change. The goal is to provide adequate calories, proteins, and lipid. And we have to compensate for ongoing losses if it is extremely low birth weight baby. The various studies have shown beneficial effect of restricted intake on incidence of PDA, BPD, neck, and death. So if you have a situation of hyponatremia with weight loss, there is sodium depletion and you need to give sodium replacement. When it is hyponatremia with weight loss, it is dilutional hyponatremia. So you have to restrict the fluid. If it is hypernatremia with weight gain, it is salt and water load and need both fluid and sodium restriction. So for ELBW and VLBW babies, you can give proteins up to 4 to 4.5 gram per kg per day and lipids around 3 gram per kg per day. So on day one, you can start with proteins around 1 gram and you can step up by 2 gram, 3 gram every day, or you can directly go to 3 gram per kg per day. And this TPN has to be started within first hour of life. So you have to put umbilical line or PIC line and start TPN as early as possible. And as I said, stable preterm should receive enteral feed within golden hour with mother's own milk, or if you are fortunate to have human milk bank, then you can use donor human milk. Then very, very important during the golden hour is prevention of sepsis. So hand washing and using all aseptic precautions while handling the newborn throughout the golden hour, during the resuscitation and during the transport, during the admission. And you can use this bundle approach. So you can do all the procedures at one go so that every time baby is not disturbed and not exposed to infection. When you are ventilating these babies or using CPAP, use sterile distilled water for humidifier. If antibiotics need to be started, do it in the golden hour after collecting proper blood culture, then only start antibiotics. Then antibiotic stewardship should be followed strictly to prevent antibiotic resistance, because that is a big challenge all of us are facing nowadays. If cultures are negative after 48 hours and clinically baby doesn't look septic, stop antibiotic. And strict protocols should be there to start and stop antibiotics in your NICU. Few words about therapeutic hypothermia, because it is medico-legally very, very important. If you have a baby who has severe perinatal asphyxia, this baby should receive therapeutic hypothermia. So what are the eligibility criteria? If baby's birth weight is more than 2 kg and post-menstrual age of more than 36 weeks, and evidence of fetal or neonatal distress in the form of acute perinatal event, acidosis, pH less than 7 or base deficit more than 16, 10-minute Apgar score of less than 5, assisted ventilation continued for at least 10 minutes, and moderate to severe encephalopathy by examination or amplitude integrated EEG. So if baby fitting into these criteria, this baby should get therapeutic hypothermia in the golden hour. And Cochrane meta-analysis showed significant reduction in mortality and neurological impairment with therapeutic hypothermia. Reduction in incidence of clinical electrical seizures was also seen with therapeutic hypothermia. So goal of a neonatologist in the case of perinatal asphyxia is to identify the neonates fulfilling the criteria to start therapeutic hypothermia, and then starting it as early as possible, preferably in a golden hour. Then we have done everything, but we miss very important part, that is monitoring and record. It is very, very important. Whatever we have done in the delivery room during the golden hour has to be recorded. So Apgar score, what interventions done during resuscitation, what was the baby's birth weight, what was the temperature at time of admission to the NICU. Because this is very, very important factor. The baby comes to NICU in hypothermia, there is increased risk of death, RDS, and intraventricular hemorrhage. So very important to document the temperature of baby at the time of admission. Then when was the first dose of surfactant given? Then when the umbilical catheters were inserted, then time of starting ventilation or CPAP, and starting therapeutic hypothermia if it is used. Then very important, when you started the first feed to this baby, then time of starting intravenous fluid and what TPN you have started, time of giving first dose of antibiotics, any complications secondary to any neonatal procedures. Size and depth of endotracheal tube has to be documented, and umbilical catheters and depth of the feeding tube on X-ray has to be documented. Then after this, communication counseling of the family is a part of golden hour. So very important aspect. So includes updating all the interventions needed and postnatal condition of the baby has to be informed. And what are our further plan for this baby has to be communicated to the family. So we have to document the communication. We have to write everything what we have told to the parents, and all necessary consent should be taken. The obstetrician should also be informed about the condition of the baby, because this mother and parents are going to ask the obstetrician, how is our baby, and how the obstetrician will know. So we have to inform the obstetrician after all the resuscitation, all the stabilization is done. Then if this baby needs transportation during golden hour, the referred hospital should be informed regarding the transport. We have to give all the details to them, what is the baby's condition. So we have to stabilize the baby first, and care should be taken to maintain temperature and blood sugar level. Interventions for supporting heart, lung, and brain. So that's about golden hour. So golden hour is nothing but strong communication, teamwork, use of medical knowledge and clinical skills appropriately. So active measures to avoid hypothermia during stabilization in DR should include use of plastic wrapping, warming equipment such as radiant warmer, warm humidified gases, and adequate temperature. Respiratory support should aim to facilitate early establishment of FRC, initiate spontaneous breathing, facilitate gas exchange, and deliver adequate tidal volume without damaging the baby's lung. So current neonatal resuscitation guidelines recommend the use of 21 to 30% oxygen during. So don't start resuscitating a preterm baby with 100% oxygen. You start with room air, then you attach the oxygen tube, and then you can give more oxygen. So the important goal is to provide least invasive support needed while always being prepared for the worst. Thank you very much for patient listening.
Thank you, Ahir sir, for your such an informative talk. We will go ahead with all questions at the end of the next session. Now the next session will be by Dr. Shilpa Kalani madam from Pune. She is a chief neonatologist at Dinanath Mangeshkar Hospital, Pune. She had done an observership at neonatal and perinatal medicine at University of California as well as the Singapore Hospital. She has a multiple faculty for multiple training programs like faculty development workshop by Pedistar, advanced debriefing workshop by Pedistar, TOTs for developmental care, NRP, advanced TOT trainer. She's also got felicitated with Global Asia GCC Award in Iconic Healthcare Leader category in Jan 2022. And Madam has a multiple national as well as international presentations. So I now request Ma'am for the next sessions regarding the perinatology. And now here I want to welcome our today's MMC observer, Dr. Sachin Gaikwad sir. Definitely at the end of this session, we will take an important keynote message from sir also. So now, Shilpa ma'am, please start your session.
Good evening, everyone. Thank you for that kind introduction. And thank you, MAHA for giving me this opportunity. I'm very grateful to Dr. Ahir sir for giving, in a very brief presentation about the important topics of golden one hour management. And that actually is the gist of even my presentation. I'm not able to start my video. I'm getting the message continuously. There's some technical problem with my computer. So maybe I won't be able to start my video. Hopefully you can see my presentation.
Yes, we are seeing the first slide.
Yes.
Yes.
Yes. So So yes, whatever Dr. Ahir has just presented, I'm going to just take you all through some cases, like clinical application of whatever we've just seen. And so that's my introduction. It's going to be case-based discussion. And I'm going to discuss common but little different varieties of perinatal cases or challenging cases in our routine management. So let's start with the first case. This is a male baby born at 36 weeks of gestation. Baby was large for gestation age, birth weight was 3.8 kilograms. This baby was born by emergency cesarean section in view of fetal tachycardia. Now, this was diagnosed just before, maybe an hour before the delivery, and that's why the emergency section was taken. Now, there was no history of hyper or hypothyroidism in mother. There was no history of fever or any history suggestive of chorioamnionitis. There was no history of placental abruption causing fetal anemia or fetal distress. It was just fetal tachycardia which was noticed. There was also no history of medical ingestion. The section was taken. The baby was euthermic at birth, but very irritable. Baby was tachycardic. They could not even hear the heart rate, and the saturations were more than 95%. BP was normal. The baby was referred to our hospital in view of tachycardia, fetal tachycardia, and the postnatal tachycardia. So the baby was admitted within 1 hour of life. And on vital examination on ECG, we had started the multi-para monitor. The baby had saturations, good saturations, active but extremely irritable, tachycardic. The BP was normal. The oral perfusion was okay. There was no pre and post-Doppler saturation difference. Sugar was normal. And this was the ECG, which was taken immediately. And here you can see, there are multiple, this little sawtooth appears, there is tachycardia. So in view of neonatal tachycardia, we went through the algorithm. So the first thing, even if it is tachycardic, do not forget airway, breathing, and circulation. That was achieved. The vitals we tried to maintain. And on ECG leads, whether it's a narrow QRS complex tachycardia or wide QRS complex, it was a narrow QRS complex tachycardia. Then we tried to rule out other causes. It was supraventricular tachycardia, vagal maneuvers were performed. Adenosine was given. Baby did not respond to adenosine. Cardioversion was done in this patient, and then the rhythm was normalized. So you can see the normalization of ECG. Right? So the ECG is better. The heart rate is normalized, and you can see the normal P waves now. Here for the comparison, you see the previous ECG. You see the sawtooth appearance of the P wave. So that was atrial flutter. This baby had idiopathic atrial flutter. The investigations in terms of electrolyte imbalance, the baby did not have hypocalcemia. There was no structural heart disease. And the baby did not have even recurrence of this tachycardia. This was just idiopathic. Maybe IDM itself could have caused this tachycardia. This is how the baby was managed. So the baby was tachycardic. Cardioversion was done, which led to normal heart rate. Okay. So this was, the baby was very well referred in time without the baby, before the baby developed hemodynamic compromise. The breastfeeding was initiated in this patient on day 2 of life. Baby was discharged on day 5 of life. Let us go to the second case. This female, Dr. Ahir has just touched upon this topic. I'll just go through the case. This is a female baby, 38 weeks, born by emergency cesarean section in view of cord prolapse. Baby did not cry after birth. Resuscitation was done as per the guidelines. Abga score were not available because this was an outborn baby. Birth weight was 2.8 kilos. Because the baby required significant resuscitation, baby was referred to our hospital for further management. So the question is this asphyxia? Because we do not have the Abga score in this case. And whether this baby has HIE, we do not know. The only history we have is this baby is significantly compromised and the resuscitation was done. Now, how do I go ahead with this patient's management? So by WHO definition, failure to initiate and sustain breathing at birth is asphyxia. And this we can very well apply in this case. And by this definition, the baby was asphyxiated. The ABG was done with 1 hour of life, showed metabolic acidosis, which also support the evidence of asphyxia. So whenever there is an hypoxic ischemic insult, there are two phases. One is primary phase and the secondary phase. The initial first 6 hours, there's a primary energy failure. And if you want to do something or want to help this baby to to prevent further progress of the injury, then we have to, this is the therapeutic window, first 6 hours, and we have to intervene this stage. So the baby was referred in time within 6 hours of life. Though therapeutic hypothermia is one of the neuroprotective treatment strategy, we should not forget basic elements in managing this patient. So the basic element remains same. We need to identify these babies at the earliest, that these babies are suffering from peripartum ischemic injury. They need an ICU admission. We need to stabilize this baby's systemic physiology. By what do I mean by that? That we avoid temperature imbalance. Baby should not be hypo or hyperthermic. Baby should not be hypo or hypercarbic. The perfusion should be okay. Baby should be normoglycemic. If there are seizures, we need to control the seizures and consider neuroprotective intervention. So we have amplitude integrated EEG with conventional EEG. So this baby was started on EEG. And you can see this, the first part is amplitude integrated EEG, which shows burst suppression pattern. And this is the conventional EEG. This also shows the burst suppression pattern. And neurologically, the baby is lethargic, hypotonic, and there are no moros. The baby also had seizures. So this baby is having moderate encephalopathy, HIE stage 2. So can we cool this baby? Yes, any baby who has got HIE. How do I know this baby has got HIE? Any asphyxiated baby with the features of encephalopathy is HIE. And by Sarnat staging, this baby had moderate HIE, so a good candidate for cooling. And we just seen the evidence. There is a good amount of evidence for therapeutic hypothermia as a one of the intervention for neuroprotection in such patients. So therapeutic hypothermia was given. The baby improved neurologically. EEG normalized after 24 hours. The therapeutic hypothermia treatment was completed in 72 hours. Breastfeeding was initiated on day 4 of life, and the baby was discharged on day 7 of life. So what are the learning lessons from these two cases? Timely referral improves neonatal outcome and survival. So there are very few cases. Actually, we need to think about this timely referral in all cases. However, if it is a premature delivery, in utero transfer would be the best. Congenital heart disease, PPH, and arrhythmia will definitely have a good outcome if referred before they get compromised. HIE, to offer a neuroprotective intervention, should be referred within 6 hours of life. Acute limb injury. If you identify any neonate with acute limb injury, that the neonate has to be intervened as early as possible for the limb salvaging that baby's limbs. And neonatal surgical cases like congenital diaphragmatic hernia, if you do not manage this patient optimally in time, then this patient are going to have irreversible damage. So timely referral is extremely important for the better outcome and survival. Let us go through the next case. Now, this is a female baby born at term gestation age, appropriate for gestation age. Now, there was no antenatal risk factor. There was no history of decreased fetal movements, oligohydramnios, polyhydramnios, or fetal distress. This was a spontaneous vaginal delivery, very smooth delivery. However, baby did not cry after birth, required extensive resuscitation. Avga score at 5 minutes was 5. This was an outborn baby. The baby was admitted in ICU, intubated, was in referring hospital, was admitted in ICU at 2 hours of life. On admission, the baby was lethargic, floppy. The pupils were equally reacting to light. Deep tender reflexes were present, but not very well elicitable. Primitive reflexes were weak. This baby also had fracture in the right femur. The other systemic examination were normal. Now, in this particular case, when we see this case, now whether this baby is asphyxiated or not, as per WHO definition, yes, and we have the Avga score here now. The baby is definitely asphyxiated. So we spoke to the gynecologist and we asked him that there must be something which has happened during the delivery process that the baby is severely asphyxiated and the baby is neurologically depressed. The gynecologist was very clear and he was continuously saying no, it was absolutely smooth event and there was no antenatal or perinatal risk for the baby to have any kind of compromise. And this was a good friend. We had a good rapport, so we knew that whatever he's saying was perfect and was absolutely true. So because we had that strong history, that there was no significant prenatal and perinatal history, we thought in terms of, are we dealing with something else? Something else means we are talking about something called double trouble. What is double trouble? That the primary pathology is something else, and that has led to the asphyxia, the baby not breathing and requiring resuscitation. And this can be seen in any case, like basically in neuromuscular diseases or neurological cases or syndromes, or maybe inborn errors of metabolism and congenital heart disease as well. So baby was investigated on those lines. Electrolytes was sent, CPK was done, LDH was done. Everything was normal. Because the baby remained hypotonic for a long time, the MRI brain was done, which was normal. Karyotype was normal. Metabolic workup was done, it was normal. FISH for Prader-Willi syndrome was negative. CTG repeats were normal. This is done for congenital myotonic dystrophy. This is how we need to investigate any baby who is neurologically depressed for a long time or floppy. EMG was done in NICU, and that showed myopathic picture. This is the same baby. She is now 5 years old and she is able to walk, but however, she's thin and lean. Her genetic workup was done and it showed central core disease. So this was a case of myopathy. Learning lesson: asphyxia without any significant preceding perinatal event, rule out double trouble. Is there any other underlying cause like neuromuscular or syndrome, etc.? Because the history taking is extremely important in these cases when we do not have any clue what's going on. Let us go to the next case. Now, this is a female baby born to 27-year-old primigravida mother at 29 weeks plus 5 days of gestation. This was an emergency cesarean section in view of prolonged premature rupture of membrane. Baby cried immediately after birth. Now, this particular patient was seen by my team one day prior. For this baby's MCA PSC being on a higher side, that was 1.66 MOM. That means this baby was anemic. The mother was extensively investigated for the cause of anemia. There was no evidence of any hemolysis. There was she only had polyhydramnios. All the investigations were done, and they could not find any cause for the raised MCA PSV. So here, prenatally, the parents were counseled for all the probabilities this baby may have in case of emergency delivery. The baby was delivered, birth weight was 1.55 kilos. Now, the issues which were discussed with parents as well as with the obstetric team were, this is, the mother has PPROM, so there is a risk of sepsis. The baby is going to need antibiotics. There is raised MCA PSV. The baby is going to be anemic. However, we do not know the reason for anemia, whether it's immune or non-immune, because the investigations did not reveal anything. So we were supposed to be ready for everything. That's exchange transfusion and PCV transfusion if required. And they showed there was a placentomegaly, polyhydramnios, some skin edema. So there was a possibility of hydrops fetalis. So hydrops fetalis is a big challenge in delivery room. So we were ready with all the intubation difficulty and management of the third space fluid loss. And there was, on top of that, prematurity was the additional risk factor. And so premature babies with this kind of hydrops fetalis, we didn't know about the outcome. So everything was discussed with the parents. And because we didn't have obvious clue, we decided to see the placenta post-delivery. And the previous day only, we had arranged the PCV in case the baby required transfusion or the exchange transfusion. So the baby delivered, the placenta was examined. And what you can see here, so this is the same baby's placenta. So there was a mass here on this side. So this mass is chorangioma. Okay. And when we send the microscopy, the histopath showed multiple lakes of blood vessels here in this. So this is the baby, same baby delivered. And so this baby was non-immune hydrops fetalis, anemic. And the chorangioma is like any other AV malformation, which can lead to hemolytic anemia. So we were observing this baby for DIC liver dysfunction. The baby was investigated at birth. The baby's HB was 10.4. Counts were normal, platelets were normal, retic count was on 10.8. DCT was negative, bilirubin, baby didn't have high bilirubin. LFTs were normal, coagulation profile was okay. So this was non-immune hemolytic anemia, and this is because of chorangioma. So baby required respiratory support for 4 days. PCV transfusion was given only once, had grade 1 IVH, but that resolved with time. Feeds were initiated on day 1, full feeds achieved on day 9. So the baby was in NICU for around 33 days and was discharged with weight of 1.6 kg. So this was a chorangioma. This is a benign placental tumor. It is like AV shunting. It could be small or large. This baby had a large chorangioma. It can be seen in 1 in 100 placenta and can present with high output failure. Preterm delivery, polyhydramnios, microangiopathic, hemolytic anemia. Similarly, like this baby presented. The mortality rate is 30 to 40%. Luckily, this baby survived well and required an NICU stay for 1 month. So learning lesson is any challenging perinatal case when we do not have any clue what's going to happen, please do not forget to examine placenta. Ideally, placenta should be examined in each and every case. Whenever there is little dicey prenatal history, the perinatal transition of the baby and baby requiring NICU admission, placenta should be examined. But surely in cases which are challenging, where you do not have clue what's going to happen in that particular baby. In this particular case, parental counseling definitely helped. Not in this particular, any patient who is likely to need an ICU, or any mother who is undergoing cesarean section or any emergency delivery or has any adverse perinatal outcome, parental counseling is extremely important. And it should not be on-site, crash counseling. It has to be prenatal counseling, good prenatal counseling. Next case. So this was a baby who was referred with these images. So we received a phone call that there's a baby, look at the images and please plan the management. So this was a call from the obstetrician. We were very grateful that we have a good obstetric team. So the baby, you can see the image, right? Here you cannot see the mandible. The baby had clinically severe micrognathia. And we knew by looking at this, so this was the mother was referred at 36 weeks of gestation. And we knew that this baby is going to land up in problem with the airways. So we decided to, this baby was likely to need exit. Mortality risk was high and was needed genetic evaluation. So everything was explained to parents that time only. Also, it was a team which did parental counseling, and that team included, so this was the MRI, which also showed there was severe micrognathia. So the team included obstetrician, pediatric surgeon, and ENT surgeon. So the neonatologist was the core member, and everything was, so obstetrician was kept in loop. Even anesthetist was kept in loop. So obstetrician was kept in loop because this baby was requiring, possibly requiring exit, and hence the delivery, accordingly, delivery room was planned. Delivery management was planned. Anesthetist was kept in loop because accordingly anesthesia should be managed. Pediatric surgeon, ENT surgeon were kept in loop for the airway management, that's tracheostomy. So they were, so everything was discussed with parents that this baby is severely micrognathic, is going to have respiratory compromise, and we're going to need exit, and we may have to go for tracheostomy on table. So this was 2 days prior, and after Tuesday, in middle of the night, I received a phone call saying that the same baby the mother has come with a fetal distress, and we are taking her for emergency section. So you can see, it was a very hyper situation. So from 2:30 to 3 on the way to the hospital, I made so many calls. We called pediatric surgeon, ENT surgeon, obstetric nurse, NICU fellow, and obstetrician. And the specific instruction was given, whatever happens, do not deliver this baby. Even if you deliver, I will not be able to do anything in this particular case because I have to have the entire team on board. Now, luckily, everything was planned 2 days prior and everyone was on board. That's why we could, in the middle of the night, everyone was there in the delivery room, and accordingly, the procedure was planned. So what is important when you plan exit is the equipment placement and the ergonomics. Rahel sir just discussed about ergonomics. It's very important. Parent counseling in the middle of the night was important. So we spoke to parents. They were already knowing all these things are going to happen. Consent was taken. Team briefing was done. There were 2 resuscitation trolleys which were kept ready. One at the mother's side and one at the newborn resuscitation corner. And the tracheostomy tray was also kept ready. So the plan was we try intubation, if not possible LMA, and if not possible tracheostomy. But we were not waiting for, we had planned not to wait for all these steps. We were simultaneously planning to take the baby for tracheostomy because intubation and LMA, it was just a matter of seconds that we knew that it would have been obvious that the baby needed advanced respiratory care. So challenges in this particular case was this was an emergency cesarean. This was not a planned section. This was an emergency section in the middle of the night, and the anesthetist had trouble, had challenges in giving general anesthesia because she just had a food. So this was all done under spinal anesthesia. This is a short video for exit. Okay, so So we can see that the head was delivered. The baby was delivered. Only anterior shoulder, baby was delivered up to the anterior shoulder. I tried intubation. The baby was severely microkinetic. I could not intubate. Okay. LMA was also tried, could not put an LMA. You can see there's no mandible. Then we planned for tracheostomy. You can see baby is partly delivered. Tracheostomy was planned. Okay, so ENT surgeon or pediatric surgeon both are doing tracheostomy. You can see that. The tube is inserted and tubes sutured. The baby was then delivered completely. You can see the baby was okay, pink throughout. It's completely delivered. Then the cord was clamped and cut. Then the baby was shifted to the resuscitation corner. So ABG within 1 hour was 7.22. So ABG was absolutely acceptable. This procedure actually was continued for around 30 minutes. Everything from the time of delivery to the exit of the baby. Baby required CPAP, had pneumothorax, ventilated for 2 days, needed oxygen for 7 days, and was discharged. So this was this was Ignathi autocephalic complex. The mortality is very high in this patient. So they opted for withdrawal of care. But the learning lesson from this particular case is parental counseling, team briefing, and equipment checklist is key to successful delivery room management. Difficult airway management flowchart should be put up in labor room because you do not know what's going to come ahead. So difficult airway management flowchart has to be there in labor room. LMA should be available in labor room because LMA is good. Sometimes there are just trainees available, and then if they are not able to intubate, LMA is a good equipment for securing the airway. Next case, a female baby, 33 weeker, primary gravida mother. Now this is what we have everything. We knew that what's going to happen. Now this is a case where we don't know what's going to happen. This is a primary gravida mother with no risk factor. Emergency cesarean section was done. Baby did not cry after birth. Intubated and transferred to DMH. Now you can see this was the referral hospital. We had to do the delivery room management in the referring hospital. You can see the baby. The baby is completely edematous. Okay. This is a hydrops. Okay. So it was emergency section. We didn't have any clue that this is going to be a hydropic baby. However, the transport team had everything with them. So you can see the pitting edema. You can see the skin edema and pleural effusion. So in delivery room, thoracocentesis was done. You can see the pleural fluid has been aspirated because unless we do this, the baby will not have a good outcome. So in hydrops, you have to be ready for thoracocentesis, if required pericardiocentesis and ascitic tapping. So this is the baby's X-ray on admission. This is the baby post tapping. You can see there's a difference. Okay, so the baby was investigated. So the baby did not have, this was a non-immune hydrops and had a genetic cause for hydrops. The baby was ventilated, then was put on CPAP and low flow oxygen. TPN was given. Baby required PCV, FFP and albumin. Antibiotics were given. This was the baby on admission. This is the baby at discharge. So again, the timely management and so learning lesson from this case is failing to prepare is preparing to fail. Equipment checklist strictly be followed in labor room. However, whatever is the case, whether it's a without risk factor or with risk factor, equipment checklist is must in labor room, and LMA should be made available in labor room. Now this is, I think, last case. Yes, last case. This is a male baby born by normal vaginal delivery, cried immediately after birth. Appropriate for gestation age. Baby was referred for respiratory distress on day 3 to the local hospital and day 5 to DMH. Now, in these 2 days, baby was given cholesterol, levoflox, and a lot of antibiotics because this baby was febrile. So, because the baby had high grade fever, the baby was referred to our hospital. On examination, the baby was irritable, febrile, had prolonged CRT, had respiratory distress, was put on CPAP. The first differential what we had kept was late onset sepsis. Baby was investigated. You can see this is the baby. These are the baby's limbs. You can see some edema on the limbs. And the baby was extremely irritable to touch. The moment you touch, the baby used to be irritable. The baby was investigated for next 2 to 3 days. Baby had persistent thrombocytopenia. We continued with the antibiotics initially, but now because we were not seeing any kind of improvement in the baby clinically, we decided to take detailed maternal history. Because this was an outborn baby, the mother was not available. And when the mother was discharged, and she was in front of us, we asked everything. Sometimes mothers don't give detailed history. So when we asked her, she said that she had history of joint pain and her joints were swollen. So now we knew what we were dealing with. The baby was irritable, was febrile, had joint swelling, and there was a history of joint pain in mother. So we sent investigation. Baby had chikungunya. So this was a chikungunya, and so the clinical features are these patients have abrupt onset of fever, have myalgia and arthralgia. They may have uveitis, retinitis, myocarditis, nephritis, hepatitis, myelitis, and meningoencephalitis. The skin involvement is seen as pigmentation in central facial pigmentation. The case fatality rate is 1 in per 1,000. Diagnosis is diagnosis of exclusion. Virus isolation is done in first 3 days. PCR is done in first 7 days. IgM after 5 days of illness. And differential diagnosis is dengue or Zika. This is the baby. Afterwards, you can see the central facial pigmentation. So the learning lesson is febrile neonate not responding to antibiotics, rule out non-bacterial causes of infection. Detailed maternal and family history is clue to the diagnosis. Now you know that currently, you know what viral infection is going on. It is RSV and flu. There are a lot of patients coming, febrile neonates coming with respiratory distress and fever, and these are all typical RSV. So we need to also take into consideration what's going on around the epidemiology of that particular baby, from where that baby is coming, what's the kind of infection going around. That also needs to be taken into consideration. So take home message, history taking is key to focus management of challenging neonatal cases. Team briefing, parental counseling and equipment checklist prevents delivery room crisis. Difficult airway management flowchart is must in delivery room. I have not included this. I felt that this everyone must be doing already. Head to toe examination of neonate and pulse ox screening help preventing sudden neonatal collapse. Thank you.
Right.
So,
Sachin, a lot of learning today, correct?
yes, sir, definitely. More cases, more learning lessons.
Both the teachers, like I will tell specifically about the Ayre sir and Kalani madam, both have done a very good job for today. And I just have some questions here, particularly for Kalani madam.
Okay.
So you talk about one place where they done the thoracocentesis in one of the slides. So was the ultrasound guided or is like because of some emergency you done just blindly? Because most of the times it is not available with us in the delivery room.
Yes.
We might have in the NICU.
No, good question. But this was a delivery room management. It was done in delivery room.
Oh.
Can you hear me?
Yeah.
Yeah, so this was a delivery room management. In delivery room, we do not have ultrasonography, and we cannot move ultrasonography from a machine from one floor to another floor in case of any emergency, because there are so many strict laws for this. So this was a baby who was hydropic at birth, was intubated, though it was difficult, we could intubate. However, the chest rise we could not achieve, and the targeted saturations we could not achieve. So we did this one, thoracocentesis in delivery room.
Okay.
Samisa, another question is there on therapeutic hypothermia. Now I request Sanjay Ahir sir. So what is your take on therapeutic hypothermia, especially in developing countries? Cost and benefit.
See, now it is medico-legally, it is mandatory. Even if you are in developing or developed country, it doesn't matter. If you have the facility, you start therapeutic hypothermia or find a unit where you can transfer this baby in next 1 or 2 hours so that they can start therapeutic hypothermia. We cannot sit on this baby without doing what is required for this baby. So if you don't have hypothermia, therapeutic hypothermia, you refer the baby where this baby can get therapeutic hypothermia. Because even if in India, we have centers where they have therapeutic hypothermia treatment available. It is a matter of 1 or 2 hour journey for the baby, but it should be started.
Oh, yes. Thank you, sir. One question is regarding Helix trial. Shilpa ma'am,
Yes.
any idea regarding Helix trial? Will you elaborate?
Elaborate. There is a good paper available on internet, and there is a lot of
Okay.
critical appraisal as an answer to that. But what I would say is that, see, therapeutic hypothermia, it's not, if somebody wants to start therapeutic hypothermia, is just start it. Starting therapeutic hypothermia is a big decision. It needs extensive training of the staff. It's basically you're starting a neurocritical unit. So it needs extensive training of the staff. You have to have a good machine. You have to have a good monitoring. And you have to have a strict SFC protocol. Unless you have this, you cannot start therapeutic hypothermia. So if we have compromise in this, then therapeutic hypothermia is not going to work. We have to have strict monitoring, strict selection, and strict trained staff. We are cooling the baby since last 2000, like 2011, 2012. We have not seen side effect of therapeutic hypothermia.
Actually, we should have arterial line also and umbilical line, like both arterial and venous lines has to be there.
Absolutely, absolutely. Invasive blood pressure monitoring is extremely important in such cases, because you can have the baby receiving therapeutic hypothermia is overdiagnosed to be septic, overdiagnosed to be in shock if you go by just clinical management. So you have to have a invasive BP monitoring in such patients.
Couple of patients I have, that was some emergency in the form, like they start with we start with the hypothermia, and we take the signature from the parents that we are going to take for 3 days, and suddenly after first day they thought that child is not going to survive or child is going to have some problems, and they want now to shift such patients outside. So as you know that we are doing the hypothermia, we are reducing the temperature by 1 to 2 degrees Celsius Fahrenheit. And then the most important thing in this is to increase the temperature only by 0.1 degrees Celsius per hour maximum allowed. So as soon as you take out from these patients from the hypothermia and give back to the parents, or send to some other hospital or some other place, that cannot be maintained, and that's caused more injuries. So has to be improved. That communication has to be happen with the parents that hypothermia going to happen for 3 days. So it's not a point of just midway you leave this patient or not do anything
Not
that
at
way.
all. Yeah, it's going to cause more damage.
It's more damaging. So either you do hypothermia, if parents are not willing, you should not go ahead with this therapeutic part, because possibility that even after doing the hypothermia measures, child may remain hypoxic, ischemic injury and brain damage may happen later on. So be sure on communications, document all these communications, and remind this to the parents every time that we have done this in a assumption that the child will going to help him for these purposes. And the standard of care nowadays in all tertiary care centers, we should have therapeutic hypothermia related facilities available with us.
Ramakant sir, will you enlighten us regarding medical legal aspects of hypothermia, therapeutic hypothermia?
No, Sanjay knows better. I don't know about the NNF position and neonatal IAP position about the therapeutic hypothermia, because I am not yet aware that whether it will be a medical legal issue, because there is no clear-cut mandate. But Sanjay, as mentioned, Sanjay might be able to throw more light on that, because if it is available, then we have to give. Then in that case, it becomes an act of omission. But if it is not available, and if it is available, as rightly Samir has said, that we have to weigh how much damage is going to be done by not giving cooling, and how much damage is going to be there if we are improperly transporting the child. That is to be counterweight like that. And Sanjay might be able to. And I just wanted to ask both of them, is there a head-to-head comparison between whole body cooling and head cooling alone? Is still the head cooling in hope, or it is only whole body cooling?
Head cooling, nowadays whole body cooling is done, because it is said that with the head cooling only the though theoretically there is no difference in outcome, both are equally same. However, it is said that head cooling does not really cool the deeper parts of the brain. So theoretically, both are same. You can use it, but whole body cooling is preferred.
I think you can arrange one separate lecture on therapeutic hypothermia.
Yeah, absolutely.
You can be an
Definitely, sir.
expert in this field, because what we said, it is medically mandatory. If you don't have therapeutic hypothermia, you give option to the parent that this baby might do better if this baby is transferred to such and such center where you will have that facility. Otherwise, this baby is going to have long-term neurological impairment. If you have all the team and everything, you start therapeutic hypothermia. I think we'll need a separate lecture because it is a huge topic, and it will take 2-3 hours to discuss this topic.
It is a standard of care. It is a standard of care in asphyxia or HIE, but there is no clear position of IAP on that, or even of NNF, whether it will become because it is a standard of care. So for that matter, anything which is standard of care, if you are not giving, that becomes an act of omission. But there is no clear guideline that if you do not give, it will be a medical legal issue.
NNF has a position statement on therapeutic hypothermia. And
it is
they
a
have
standard of care. It is a standard of care, but it doesn't
Yes.
become a act of omission.
Almost no further questions. Samir sir, you are having some questions?
No, I
On
don't have
chat box,
questions, but I definitely
chat
will
box.
say that couple of cases were very extensive. Like I was very happy with that. One was I think chorioangioma, because we never do placenta check. We just say what is the weight. Like we don't pay attention. As soon as the baby comes out, we are busy in doing cut, tie, knotting, and then seeing whether child is crying or not. But today, Dr. Kalane has basically mentioned about that we should start looking at the placenta also. And this was very strange and also something new. I have not heard of or seen of it actually, of having the chorioangioma and how it affects the child actually. So that was a very nice, good lesson. And other thing is like having the micrognathia or retrognathia. Couple of patients I still remember working in the sick kids Canada was having uh, putting the balloon in the areas, and that can help. That is intervention to be done before the pregnancy. So intra-aortic balloons are there, which are available. That can be tried once in a while. And I have one more question also about the Lisa. I still have some confusion, Dr. Ayers, sir. Like how frequently you do Lisa at your place? Whether you also go for intubation or not intubation, or is it a timely thinking, or is just like a blindly think of which patient we should go ahead with doing the intubation and which patient we should not do with the intubation?
See, I start these babies on NIPPV mode, preterm babies. And if their oxygen requirement is just borderline 30-40 and X-ray showing moderate RDS, I don't intubate immediately. We do Lisa. But if the baby is intubated by some other reason, like if you have to intubate the baby, then you have to give surfactant and keep the baby ventilated for a short time and then extubate the baby. But it is practically possible. We are doing it very frequently, Lisa, and we have these catheters available, surf cath. And it is very easy actually. It is more easy than endotracheal tube to put the
that's true.
catheter and give surfactant.
But because there is a policy between different types of NICUs, some people definitely go for Lisa and some definitely not go for Lisa.
I have
So
shown
that's
that
a personal
evidence
choice.
also. It has shown it is better than insure. So why not follow the evidence rather than what your unit have and what your unit don't have? So this is the evidence, and we have to get skilled in this technique. Because it is not very easy. Because intubation is very easy, but Lisa sometimes in the beginning it is not that easy. You have to be improve your technique every time. Next time you are doing this, so you learn every time. So initially there were studies whether it is feasible or not. And then we got the result that it is feasible in Indian scenario also, and it can be done.
One more important thing was also having the available out of LMA, laryngeal mask airway. So very simple formula is there actually for all laryngeal mask airway, how to use. For general population, I'm just telling about is like in the pediatrics or NICU, it's like 1 plus body weight divided by 20. So according to that formula, suppose your child mostly in the NICU is around 2.5 kilos. So we can use from 2.5 kilo to 5 kilos very easily laryngeal mass LMA number 1. But there are a lot of studies which have shown that even a weight as less as like 800 grams or even 1 kilo, they have successfully used the LMA type 1. Or otherwise, suppose your weight is between like say 20 to 30 kilos, you can definitely use number 2, number 3 for 30 to 60 kilos, and number 4 for 60 to 80. So it's very simple formula: 1 plus body weight divided by 20. So body weight, suppose you are according to what is your weight, divided by 20 and add 1 in that. That's a very easy way to use the laryngeal mass airway. So a couple of times we have used this one because we failed to intubate such patient, particularly in the NICU. Nobody knows how and whenever we can get the difficult airways. So standard of care, we also includes nowadays to have LMA even in the newborn period. Regarding the Apgar score, a couple of times the speaker has mentioned about, but it has lost the value, but it still has some value sometimes for prognostication, because this is the added thing which we can explain to the parent that birth asphyxia or any other places where the child becomes sick later on, giving convulsions or some other abnormal issues, that we can have predict and tell us that there was Apgar score which was very low. So there still has some meaning to do it Apgar score when you have sufficient manpower with you.
Yeah, it can
So
be
thanks to
done.
both of speakers.
When baby comes to the NICU, you can write down the Apgar, because it's very important. If that baby is going into Mahatma Phule Yojana, they need Apgar score. What was the Apgar score of that baby?
It is better that it is calculated. One can easily write it even later on also, like what was exactly the Apgar score.
Yeah.
So that is good.
And when it is
And
related to preterm baby, it's better to use expanded Apgar score than the plain Apgar score.
Correct. So team briefing and history still has the meaning, and we should go ahead with doing all these ones together.
Yeah.
Anybody else wants to ask any other questions? It is okay. Platform is open for everyone now.
Sanjay,
Yes, sir.
my conjecture about Lisa is that Lisa and Misa are same. Are those are really same? And how costly are these catheters for Lisa?
It is, the catheter costs around 1500 to 1800 rupees, and
Okay.
you can ETO sterilize one catheter and you can use 2 or 3 times. So you can divide the cost. It may be around 500 for per baby. So, and Sandeep has done one study in KEM. You can put your feeding tube in deep freezer. It becomes steep. 6 number, 7 number feeding tube. When it is frozen, it becomes steep. You can use that also. So
Wow.
it will cost you 50 rupees maybe, rather than going for these very expensive catheters.
We use feeding tube only.
Okay. And how you put them in non-invasive like CPAP, and after how much minutes you give it on? It will be always a rescue, Lisa, no?
Yeah, you wait and see what happens to the baby. If his respiratory distress is worsening, but it is not Selvon's score not more than 5. You give Lisa, put the baby back on CPAP and see. Sometimes it might fail. You have to intubate the baby and put the baby on ventilator. But that's okay. We have to give one chance to the baby. We can avoid intubation and all the complications related to mechanical ventilation.
And what is this mist surfactant therapy?
It is almost same, sir. फक्त ते नावाचं juggler आहे फक्त.
Okay.
Whatever. You have to put the catheter in the vocal cord and give it.
Okay. So my conjecture is same, like it is both are same. There is nothing difference into that. Okay. Thank you. It was really wonderful cases, because we are always at sea for non-immune hydrops, and there are so many possibilities. And I really applaud the intensity, persistence, and perseverance to go to the hilltop situation in all cases, and wonderfully presented by Sanjay as usual. What are the NRP newer guidelines and what should be done in delivery room? Wonderful. That was many newer insights were there for first golden hour management. Thank you. Over to you, Samir or Neha.
Yeah. So Sachin is something.
No, now I request, I think all questions are covered. Now I request Neha madam our EB MAHA IP, ma'am. Please go ahead with the vote of thanks.
Thank you, Sachin sir. Like so many medical professions, those who work in the NICU are really unsung heroes, fighting every day to give tiny, precious lives a chance. NICU is such a special place, a place full of hope for parents and their little hearts. Those tiny souls, even the little primees, can pull through and fight, grow up to be strong, powerful people. Myself, Dr. Neha Singh, co-chairperson Women's Committee, would like to thank our MAHA IP President, Dr. Ramakant Patil sir, and our Secretary General, Dr. Amol Pawar sir, for organizing this beautiful academic subspecialty CME on Little Hearts. I also thank Dr. Vasant Khalatkar sir for finding time from his busy schedule and giving us his blessings. I like to thank our experts, Dr. Sanjay and Dr. Shilpa Kalani ma'am, for an excellent brush up on pediatric neonatology and wonderful cases. Then I would like to thank Maharashtra Medical Council and Dr. Sachin Gaikwad sir for granting us 1 MMC points. I thank Dr. Sameer Sadavarte sir and Dr. Sachin Patil sir for conducting this session. I thank the pillars of our branch, all the EB and OB members of Central IP, MAHA IP and district branches. Thank you all for being so supportive and active in each activity of our state branch. Last not the least, all the attendees on Zoom as well as YouTube Live, requesting everyone to please join us tomorrow also at 9:30 p.m. for our monthly CME on immunization dialogue. Thank you all and good night.
Thank you. Thank you for the opportunity.
Thank you.